The last lecture. And thankfully they didn't have me do right before lunch, but are having you guys eat lunch while this is going on. So that's much better for me. So, because I don't want to get between anybody and food. So sorry that you guys are going to have to hear a total of 2 hours of me talking today, but this is the literature review for this. This is going to be a little bit more relaxed. So if you have questions, we can probably work them in as we go. But we're going to fly through it, ignoring most of the nitty-gritty, nerdy details that I care about. No one else does. Unless the audience wants to chat about it, okay? So, don't have any conflicts of interest. Let's get to this. So, if it's got a black background, this is a good article. It's one that you ought to know about. If it's got a red background, it's a critical article. You must know about it. And these are just ones that I threw in to spice it up because otherwise this gets really boring. All right, so vitamin C and sepsis. We actually talked about this a little bit yesterday. This is a good old-fashioned Marik paper. Came out about 1.5 years ago, set the world on fire. So this is not a randomized controlled trial. This is basically one shop changing how they take care of people with sepsis. So it's before and after, okay? These people are not randomized in any way. So everyone that was classified as severe sepsis at this center is just before and after, okay? They got a combination of hydrocortisone, vitamin C, and thiamine. I'm not giving you the doses because I don't think you should do this yet. And the mortality rate was ridiculously different. Okay, so you had 8.5% of people were dying of sepsis after they did it, and 40% were dying before. Okay, pretty impressive. So what are the problems with this? Well, one, it's retrospective. This would be awesome if it was a randomized controlled trial. Okay. Two, it wasn't blinded. Okay, neither side was blinded, neither the patient nor the people doing it. So since you're the one that's signing up the patients, and it was supposed to be consecutive, there's probably a little bit of hanky-panky about what exactly is sepsis. Okay. So that's probably part of this. And are these results too good? I mean, we're desperate for anything that would get a 1 or 2% improvement in sepsis care, right? And they just had an improvement of how much? 30% plus? It's ridiculous. So what is the take home? This is really cool. Stay tuned, but don't do this yet. They've actually already run out of vitamin C at a lot of places. You can barely find thiamine for folks that need it, and there were steroid shortages as well. So some people are already doing this. You should know about it. It's going to be on CNN and all this. A lot of centers, MCG included, are actually looking at participating in randomized controlled trials to actually prove this. If he gets 10% of the benefit that he actually says that he has in an RCT, he'll deserve a Nobel Prize. It'll fundamentally change what we do with sepsis. Right now, it fits into the cool but not ready yet category. Let's talk about low-dose ketorolac, or Toradol as everyone else calls it. So this is a paper by Motov. This is a good researcher that keeps doing a lot of really clinically applicable research on pain. So what is your dose for Toradol? Traditionally, we're doing 60 if you're putting it IM and 30 if you're doing it IV. That's probably garbage because if you look back at where that came from, nobody really knows. People just sort of did it, and the person that taught you to do that didn't really know where it came from either, and it just kind of got perpetuated. So they actually looked at 10, 15, or 30, all of these being IV, and they just saw what happened for pain control. And sadly, there was no difference, okay? So whether you're given 10, 15, or 30, doesn't matter. The pain control was the same. Interestingly, the adverse effects were the same as well. So it wasn't obvious that anyone was actually having problems with these, but it's just a little bit wasteful, okay? It's also unlikely that we would have seen a lot of adverse effects from this because most of the risk of Toradol actually comes downstream. It doesn't make a lot of sense, but it actually is associated with a higher risk of GI bleed than other oral NSAIDs are. Right? So remember, the way that GI bleeds get caused from this is not because it's directly caustic to the gut. This happens because of what it does to prostaglandins, okay? So don't think that just because it came in a needle, it doesn't affect the GI system. It absolutely does. In fact, it's a lot more toxic to the GI system than any other NSAID that we use. Please also do not give oral Toradol to anybody if you like them. It's not a good drug at all. The only reason we like Toradol in IV form is it's the only one we got for parenteral use. So if you need to put it in a needle, this is the one that we have in this country. There's nothing magic about it. In fact, there's a lot of other ones that are probably better. So the take home from this one, I give 15 milligrams IV and 30 milligrams IM. There may be slight differences in how quickly it works that way. I see nothing for or against the doubling of it when it's IM. There's evidence that it's fine not to double it if you don't want to. The reason I go with 15 and not 10 is the formulation we have at our shop leads a really goofy fraction. If you actually try to order 10 milligrams, like 6.3 mLs or something like that, or our nurses hate it. So if you just go with 15, you're cutting it in half, reducing your likely toxicity, but that's not proven. So, death by selfie. Okay, so this was actually a collection of cases that were reported of people that died while trying to get a selfie. And this is dark humor, and I'm sorry, but I couldn't resist it because of some pictures. So, this was a literature review. There were actually 75 people that died. Surprising no one, most of them were men, because men are dumb. And there was absolutely no data on the number of injuries. These are only the people that died. So there's probably thousands of people that did stupid things and then like fell off the curb while taking a selfie for every person that died. There was actually a Russian campaign to prevent injuries, and I'm going to show you some photos from that because it's just too good, okay? It's interesting, the breakdown of how these people died, okay? So falls, far and away the most common, right? Makes sense, you're on the cliff edge or you climb somewhere high, kind of makes sense. Car crashes, which is really weird when you see people that are recording things for YouTube as they go down the road or FaceTiming while in traffic, really bad idea. So not terribly surprising that there were some car crash selfie deaths. Train injuries were interesting because these were both people falling off of a train as well as being hit by a train. So they're doubly dangerous, okay? Animal attacks, because there were lots of people like, oh sweet, there's a tiger over there, and they would like do like this, and then like literally they would get attacked by an animal. That actually happened a lot with dogs as well as a lot of wild animals. A plane crash was completely unexplained, and I don't know what was going on there, but there was an attributed death due to a selfie causing a plane crash. And my favorite was a grenade. And they said nothing about this, but I am fascinated what was going on when someone pulled the pin on a grenade and then took a photo. But they really didn't explain what happened. I think this is one of the great unsolved medical mysteries. Additionally, the Russians, being as subtle as they are, did a public safety campaign on this and released some of the most amazing images ever for Soviet propaganda. So this one I just particularly love, of this guy just standing in the middle of the road. Apparently 2 cars are coming at him. I really like this next one. That's just a good tattoo. If anyone's looking for an idea for a tattoo, that one's just awesome. This one of the guy hanging off the train while taking a selfie is apparently like surprisingly common. I don't know why. It seems like a bad idea. And this guy, like, I don't really know if a public safety campaign is going to get this guy. He's already climbing high power lines and taking a selfie. He's just not going to listen to you. He's made life decisions already. So let's talk about contrast and kidney injuries. So it's increasingly apparent that PO contrast is largely garbage that's not needed very often. IV contrast for some things is probably good, okay? But what do they make you do? You always got to get that stupid creatinine, right? And then what if you got someone that's sick that also has renal dysfunction and you're like, oh, I kind of need that study to get a CTA to look for pulmonary embolism or something like that, but I'm really uncomfortable because their creatinine's a little bit up and I don't want to hurt them, right? So this is the best paper to date that shows a lot of that's hot garbage. So this is by Henson et al. They looked at a whopping nearly 18,000 patients. This is retrospective, it's not an RCT, and you will never see an RCT on this topic because IRBs won't approve it. But you got 18,000 folks that got scanned. Or that were included in the study. Some of them had contrasted scans, some of them had non-contrasted scans, some of them were just regular ED patients, and they matched them, okay? They had absolutely no difference in the rates of kidney injuries whatsoever. Importantly, I don't really care what your creatinine goes to, I care what happens to you, okay? So your creatinine can be any number, I don't care. If you don't need dialysis or you don't have a patient-oriented harm like mortality, don't care about it at all. So there was no increase in dialysis, no increase in renal transplant, no sign that any of these people were hurt at all with modern contrast agents. So this was very patient-oriented. It looked at something that we care about as opposed to exactly what point of creatinine it was, even though that actually didn't show at all. It was based in the emergency department, okay? So they were actually looking at real, living, breathing ED patients. And there was no signal of harm whatsoever. So there wasn't even like a little trend, and maybe if we had 40,000 instead of 18,000, we would have picked it up. In fact, it looks like IV contrast may protect the kidneys, which is not the case at all, but that's absolutely what it was signaling, if there was any signal at all. So the take home from this, if you need IV contrast, get IV contrast. I get that me lecturing to you on this is not going to convince your radiologist that you no longer need to order creatinines for this because they won't listen to you, okay? They just won't. However, I want you to pick up the phone and call them. If you've got someone with a creatinine of 2.5 and you really need a CTA because you think they have a pulmonary embolism, talk them into getting it because it's very unlikely to hurt their kidneys and the risk of something important being missed is way higher than the risk of this theoretical harm to their kidneys that really isn't documented with current agents, okay? So fight for your patient if you really need that IV contrast. So topical pain relief. Someone asked earlier about topical pain relief. This is critical. So this is a Cochrane review of a whole bunch of articles, okay? And the take home from this is that there's something that has to replace the percodoodles, okay? You can't just say, I hear that you're hurting, I'm not giving you anything at all, and hope for the best, because they're gonna find another doctor, and eventually someone's gonna make the mistake of using opiates for long-term pain. So what we ought to be doing is topical relief, and this looked at quite a few different things. The most studies that they found were actually for topical NSAIDs, okay? So a number needed to treat of 3 for acute pain and 5 for chronic pain is impressive. There are very few agents that are nearly that effective, and so these are actually quite good. So you might hear Voltaren gel as the brand name, but there's actually a few different formulations of this. There's not much difference between them, but whatever topical agent you can use, go for it. Depending on the formulation, Voltaren is kind of expensive, so be aware of that, but this is an option, particularly for folks that can't take the systemic side effects of oral NSAIDs because this is a local relief. There's very little systemic toxicity from that. Capsaicin cream hasn't been studied well enough, unfortunately. I use it all the time in my practice, but most of the data looks at neuropathic pain, such as post-herpetic neuralgia. It's very evidence-based for that. The few studies they have for things like back pain look very positive, but we need more data on it. So what am I using? I'm using diclofenac gel, particularly if they can't tolerate systemic NSAIDs of some sort. I'm using capsaicin cream. This has largely replaced muscle relaxants for me for things like low back pain and so forth. And lidocaine, there wasn't enough data to actually be included in this, but there are some studies that are increasingly interesting about topical lidocaine. I don't like lidocaine if someone has a big area that hurts because you just can't apply enough to actually address it. But I do like lidocaine for those folks that have very focal back pain. There's that one spot that hurts. Either using that as a topical patch or just doing a local injection makes a lot of sense for that. So take home, I think a lot of these patients with pain should have a PO or topical NSAID plus capsaicin cream. That's my go-to for the vast majority of back pain patients I see. So this one was one of those you stumble across and you're just like, I can't believe that got published. So hiccups makes you miserable, right? And we only have one approved drug for it by the FDA, so Thorazine. It's got some side effects. I don't recommend this as something you could try, but it looks like the digital rectal exam cures hiccups. And I just think you should know. This picture has nothing to do with the digital rectal exam, but was just too good not to include. Success. But there's actually 2 case reports of people using this to cure hiccups. Also, someone used it to cure SVT. So earlier during the EKG lecture, I was disappointed that people said adenosine. No one suggested the rectal exam. Unfortunately, there's actually a case report of a digital rectal exam causing VTAC, which that's got to be a really awkward patient safety note of just like, what exactly happened when this patient had VTAC? Well, we were trying to cure SVT and they converted to VTAC. It's a problem. This phrase showed up in every one of these, slow continuous circumferential motion, which is creepy and oddly specific for them repeatedly mentioning that specific phrase in these case reports. So if you want to have a conversation with your patient about how you're going to cure their hiccups, make sure that you say that it's slow, continuous, and circumferential. I don't think they're going to say yes. Maybe stick with the Thorazine. Next up, ketamine's awesome. We need to use it safely. You should just slow it down. This is another one from Motov, just a great researcher doing some good stuff. This was a blinded randomized controlled trial. They took 24 in each group. One group had what was described as a push, but actually took about 1 to 3 minutes, okay? This wasn't a quick push, okay? If you ever see a nurse taking ketamine and just going in like just a few seconds, really bad idea, can cause apnea. If you have someone that's not as familiar with this agent, that's really not a good idea for really anybody, including procedural sedation. It needs to be given at least over many seconds. But they also took, for this pain scale dose of 0.3 mg per kg, they put it in 100 mLs of saline and infused it over 15 minutes, okay? So they were looking at this slow push, not a true push, not just jam it in there, versus 15 minutes. What did they find? There was less dissociation. So patients felt less floaty because you gave it to them slowly. It was the same pain control despite it coming in slowly. A lot of the effects on pain from ketamine do not have to do with that dissociation bit. It's something else that we honestly don't really understand. And why wouldn't you just give it slowly? I feel no allegiance to this particular 100 mLs over 15 minutes. If they need a liter of fluid, I got no problem with you spiking a liter of normal saline with it and just running it wide open. It's totally fine for that. But the slower you give it, the less likely it is that you're going to have the side effects that you don't want. If you do accidentally use a pain dose and it causes them to dissociate, that's generally considered a procedural sedation complication with a whole bunch of paperwork that you don't want to do. So this is a great way to sort of dip your toe in the water if your institution isn't comfortable with the idea of ketamine, because this is so much safer and the patients actually like it a lot better. Apneic oxygenation. So if you're tubing somebody, I highly recommend that you put a nasal cannula on them wide open while you intubate them. All right, went ahead, put a trigger warning here. O's up the nose, all right? This is what you're gonna be doing while you're intubating, okay? Put a nasal cannula on them. It doesn't affect your ability to orally intubate anyone at all, but it decreases the time that it takes for them to deoxygenate. So there were 2 systematic reviews, both of them incredibly positive, in favor of apneic oxygenation that happened last year. A number needed of 12 or 17 to prevent desaturation, and it increased your first pass success. Now, the reason that likely is the case is that what is it that stops you from intubating someone much of the time? It's that oh-so-correct person in the corner of the room that's counting down from 100, and say 95, 94, 93, and you're like, oh, crap. And remember, you've got a lag, right, of 60 to 90 seconds. That's what caused you to stop your intubation attempt. So it has very little likelihood that somehow this is stenting open the airway and makes it very easy to put the tube through the cords. It just gives you that extra 30 seconds that you wanted on that tough intubation. So as opposed to like giving up and then having to start over in just a minute, you've got that extra padding to be able to do what you need to do. That's almost certainly what caused that increase in first pass success. The data on this is still a little bit early. There's a trend towards improving mortality, which is shocking for something that you're already using anyway. Almost all these patients already have a nasal cannula in the room because they were probably hypoxic when you decided to intubate them. So just use that nasal cannula. It does require a little bit of coordination with RT or anybody else that's helping you, because you will have to swap over from that wall oxygen and the face mask over to whatever your vent settings are. But if you do this once or twice, you really won't want to intubate without it again. So why not? This is something that I think is increasingly tiptoeing towards standard of care. Absolutely not standard of care right now, but so many airway experts recommend it that it's a little bit weird if you don't try it. Next up, I learned about something called snake wine, which sounds awesome and is even scarier than what it really is. They actually have wine, and it's really more of like a brandy, that has an entire venomous snake in it. Apparently, you can buy this in Southeast Asia or the friendly internets. So there was a guy that bought some of this, because why not? If you're 68, let's try some snake wine. Because I really thought this was going to be like a 22-year-old. This seems like such a college senior move right here of trying to drink Cobra wine. So this guy drank some snake wine, and he got coagulopathy. And so the people there were like, I don't know what this is about. I don't know. You didn't get bit by a snake because it was dead and just residing in this liquor. But he actually had all the signs and symptoms of being bit by a cobra. They actually gave him antivenom, and he got better, okay? So this is the main reason I'm telling you about this. Every annoying wilderness medicine talk about snakes aren't poisonous, they're venomous. You can now say snakes are both venomous and poisonous. You will not earn very many friends this way. Next up, back pain, a rare event to present to the emergency department. So as people said more and more, let's not give Percocet, they said more and more, hey, how about we give benzos? Because surely that won't blow up on us in 10 years. Why not? Let's just substitute one controlled substance for another. So I was taught that Valium was actually a great muscle relaxant, and I kept doing that for a while, and then I looked at the literature, and it's bad. It's really bad. So they actually had a blinded randomized controlled trial recently. 114 patients got randomized, and these were all acute back pain episodes. So this really should be the thing that helps out with Valium. There was no improvement either at 1 week or 3 months. So they actually followed these patients for a while to make sure that nothing later happened. And it looks like Valium is really not any good. As a class, muscle relaxants aren't good. I still use them occasionally, so I'll use some cyclobenzaprine or Flexeril, but I'll often write it just to be taken at night because it is sedating and it's not a terrible drug, but it doesn't actually relax muscles very well. So because of that, I think that this is mostly a class that I'm prescribing for the side effects, which is a little bit weird, but there's really little data that this actually helps with most causes of pain. So, and this was a reminder from last year, that awesome study that was just naproxen plus Flexeril, or naproxen plus Percocet, they were all the same. And you had the same pain relief with only naproxen with fewer side effects because there's less sedation from those other things. So add Valium to the long list of things that don't work for back pain. So remember, NSAIDs are the mainstay of it. NSAIDs are not perfect, but they're really the best we got combined with the topical stuff I've mentioned. So this is a great paper, very clinically relevant. Everyone's seen that patient with that blood sugar that was high, that looks pretty good, but you look at the number and say, ugh, the glucometer says 595. I can't discharge you with that, right? And there's some magical number that seems to change with age about exactly how low it's got to get before you are. It's almost a personality test. You know that guy that won't discharge until it's 250. He's just all uptight and stuff. That crazy cowboy guy that hang glides all the time, he'll discharge 550. He's just nuts. You all point and laugh at him and say, that guy, he's going to get sued. So these guys, much to their credit, like they published some startling data from their emergency department. These guys are tough, all right? Whoever's working in this shop, they had 566 patients. The mean arrival was 491. So these are my patients. These are the people that we see. The glucometer says high, and they just came in. Their mean discharge blood sugar was 334, and they actually had multiple patients that they discharged with sugars over 500, all right? So these guys are legit. There was no association between the sugars that they were discharged with and a revisit to the emergency department or future hospitalization. These folks were not harmed at all by a blood sugar of anything detectable, okay? So, using this paper, because it's really the best evidence that we have, my number is now something the glucometer reads. I am comfortable discharging folks with any number that I can get a number on. I am totally cool with you saying, that's crazy, Dan. I'm just gonna raise my number that I had before by 100, and that's okay, right? Because this is not great data, all right? This is just not even a randomized trial, it's just following over time, but there's no association there. So what I'd really want to emphasize, it doesn't matter what sugar it is that they came in with or what they left with, okay? You need to treat the patient and not the number, which sounds great as a slogan until you really apply it and say, really, am I gonna discharge a 575 that looks great? Well, here's my take home, okay? If they look sick, I don't care what the number is. I've seen some really, really sick diabetics with sugars in the 200s, right? They actually have anion gaps. They look terrible, right? And I'm resuscitating them hard, I'm giving them a lot of fluids, I'm giving them insulin, I'm admitting them off into the ICU. They look at me funny until they see the patient and say, oh, yeah, this guy looks bad. We're taking him, okay? If they look good, I want you to focus less on the number that they leave with and more on your outgoing plan. So that guy that really doesn't want to discharge unless the sugar is below 250, did he actually change their home diabetes medicines? Did he even mention anything about diet? Did he actually arrange outpatient follow-up? Those are the things that are going to actually save your patient. Okay, this is not an issue of what was the number when you left the emergency department and then proceeded to do exactly the same stuff that you were doing before that got your sugar up to 500 to something. It's really more about what did you change? Did you actually increase their insulin? Which I routinely do. I'll often increase their insulin by 10 to 20% and tell them that they need to follow up with their general practitioner in the next 2 to 3 days. Because I'm an ER doctor, I don't really know what I'm doing with insulin, but I did something to actually do it, okay? So then when I discharge them, if they get worse, I say, like, I actually changed something. It actually looks better. If you do nothing, which is sadly the case, you just give them a bunch of normal saline, the magic 10 units of insulin until they go home, right, and then you didn't change anything, I think you're actually at a much higher medical legal risk of, well, why didn't you change the meds? That's obviously the right thing, okay? So if they look well, discharge them, but focus your efforts on that outpatient plan, not on what magical number you got in the emergency department, because that number doesn't matter. PE and syncope. This was one that actually made the national news, not just the medical literature, but the national news. It's the PESIT study, okay? So this was actually talking about PE and syncope. Amazing catch on an EKG, and I think it's actually very reasonable to look for the hallmarks of syncope, of PE in every patient's EKG that you're getting for syncope for the very reason of these things are associated, okay? So this was an Italian study. They made everybody basically rule out for PE. So the only way that you actually didn't get a CT scan was if you were low Wells and you had a negative D-dimer. So it's a little tough to actually not get a CT scan, and they scanned a bunch of folks. Of the folks they were admitting to the hospital, 17% of them had a PE, which sounds terrifying, right? Because all you got to do is admit 6 patients with a syncope, and if you didn't diagnose a PE in one of those, then you missed it, okay? Looks terrifying. And that's what actually happened. A lot of folks that were admitting to the hospital was like, you're admitting this guy for syncope, I need to get a CTA, or else I'm not taking them, because 17% is too high. What that was a dramatic overreading of this study. There's many problems with it. So first of all, there was selection bias. They admitted almost nobody with syncope in this study. Only the sickest of the sick actually got admitted. We probably admit way too many people with syncope in this country, because what do? They just stare at them overnight and say, oh, the telly didn't go off too many times, you're safe for discharge. That's really what often happens if you actually follow these people that get admitted for syncope. Nothing magic, okay? So this is selection bias if they were only admitting the sick folks, okay? They also had other signs of PE. So a huge chunk of these folks actually had clear signs of unilateral leg swelling, obvious for concerns for DVT. They had pleuritic chest pain associated with their syncope. Some of them had hemoptysis. I mean, these are patients that, honestly, I think a good clinician would have said, yeah, this doesn't look just like syncope. That guy's got hemoptysis, okay? So they would have caught almost all these patients. And really, when they did a breakdown of which ones would have been missed, quote unquote, they almost all had signs that would suggest the diagnosis. So I say this because this is a study that I don't like. It's an important contribution to the literature because it kind of moves the next study forward. But please do not get CT scans on all these folks. I wouldn't fault you too hard if you want to get a D-dimer, but honestly, if they're PERT negative, I am absolutely not chasing them further for syncope. Look closely at the EKG, make sure you don't see S1Q3, T3, look for tachycardia that's persistent, things like that. Any shortness of breath, sure, you can chase those as far as you want, okay? But don't scan everyone. 2% is your acceptable risk of PE. If you're working up patients and they have a higher than 2% risk of getting a PE, keep chasing with things like D-dimers, well scores, whatnot. If they're less than 2% likely to have a PE, stop. You're more likely to harm them by anticoagulating a false positive or cause other issues with them, okay? 2% is the magic number. This is a handful of a title, Optimizing Trauma Team Performance in Dynamic Clinical Environments. Sounds like a terrible paper. It really does. This is actually written by Hicks. He's a guy that follows very closely the psychology of how teams work. So this is how you own the resuscitation bay. You all have colleagues that if you just walk in on a code they're running, things are just perfect. The room is quiet, compressions are happening, there's no yelling, there's no one running around me like, what's the glucose? And you've all seen the alternative, right? Where you walk in and there's like a clown show happening. You're like, what is happening? No one's doing compressions for 20 seconds. You've seen both sides of this, right? What is it about that person that runs that quiet code where everything's smooth and the meds just happen and everyone's doing what they're supposed to do with no delays? What's going on there? This paper will explain why, okay? So it's how you structure your team. It discusses how you build sub-teams where you assign individuals tasks of you're the person that's documenting, you're the person doing compressions, you're doing ultrasound. In a community center, sometimes this means having people sort of step up to the plate that might not be. Because I'm lucky at an academic center, we got like doctors everywhere, right? Like I snap my finger, there's like 3 residents that show up to do a code. It's great. At a single coverage community shop, you probably don't have that. But why isn't it that you're assigning the very low yield thing of using your ACLS card to call out when epinephrine has to happen? Why aren't you empowering your nurses to do that as opposed to you doing that while you intubate them, while you're somehow figuring out how to do chest compressions? If you actually assign these individual components to sub-teams, you can actually, and this article does a beautiful way of describing it, you can actually offload that so that you can actually do the things that you're trained to do. Think of, hey, is this actually a problem with potassium? Was this tamponade? You can actually ask those questions. But I promise you that you can't do that if you're running around and actually doing everything yourself. It also discusses stress inoculation techniques, including square breathing, where you breathe in for 3 seconds, hold it for 3 seconds, breathe out for 3 seconds, and hold it. So that actually is shown to actually lower your heart rate, and you will actually be more calm. It's actually related to meditation techniques. This is used by special forces folks in high stress environments. If you find yourself spinning out of control and you're just floundering on an airway that just isn't going well, spending some time to actually do that to control yourself is actually a key thing, and this paper discusses it. You also want to mentally rehearse scenarios. So I want everyone in this room to think of the single thing that scares them the most. What is that patient that really terrifies you? Is it a neonate with congenital heart failure? Is it a crashing delivery with a blue baby? Is it an airway that's got an upper GI bleed that you just can't manage? And I want you to think about that thing and think of what you will do in advance. Because if you wait until that thing happens and you don't have a plan, it is going to go very poorly because you didn't have a plan. But if you think about it in advance enough and say, okay, I really hate congenital heart defects because those things suck, okay? And you learn about it enough until you're good at them and you have a plan and you know the number to the PICU receiving facility, okay? And you looked up the doses of prostaglandin, and you wrote it on a card and took a photo of that with your phone because you've got it ready. That blue baby is not going to scare you so much anymore. And then you'll have to find that next thing that scares you. This is what a master resuscitationist does. It looks like they know exactly what to do because they actually do, because they thought about this in advance. They know what they're going to do at their small community shop with no trauma surgeon if someone gets shot in the chest, because they've already figured that out before that GSW showed up, okay? So you're going to mentally rehearse those things. And then you're going to learn how to optimize your environment, where if things aren't right in your resus bay, you know, why is it that the vital sign monitor is over there and it's the opposite of where we need it to be while running a code? You can actually work to slowly modify your environment to actually control those conditions that are causing trouble. Is it the case that the ultrasound machine is locked up in a closet so you can't get to it when something actually bad happens? Well, get it unlocked from a closet, okay? Far better for it to actually be near the patients. So this thing applies not just to the traumas that they talk about here, because that's really the main thrust of the paper. It applies to all resuscitations, okay? It gives you very specific techniques. What I love about this paper is how specific it is. It's not just control your stress. It will actually tell you things like exactly how to do that square breathing. It will tell you things about how to mentally rehearse things in very specific ways. This was actually my favorite paper of the year. It does not condense down to quick bullet points nearly as much as how digital rectal exam fixes hiccups, but this is really, really important paper. Next up, man flu, right? We've all seen it. Some of us have experienced it. As a survivor of man flu, I'm waiting on my ribbon. So this was actually written by Dr. Sue, who was, of course, a dude in the BMJ, right? So men have higher complications rates from flu. We actually have weaker immune systems. It's entirely possible that man flu is actually a real thing, okay? So the results of this paper, a systematic review of man flu, was that men were actually suffering from worse disease. It could just be, and I think this is actually true, that women are just way tougher than men. Like, this is probably the actual result of the paper. However, man flu may exist. You know, be aware. Do we have any questions at all? Yeah. Oh. Okay. Okay. Oh, okay. Yeah, that's it. So my take-home points. NSAIDs and topical pain meds should be an increasing part of how you control pain in the emergency department. With both ketamine and ketorolac, go low and slow. Lower your dose, give them slower, you'll have fewer complications. Always use a nasal cannula while intubating. Feel empowered to discharge blood sugars, especially if the patient looks well. If they look sick, remember, do your job, take care of them, and then focus on how you're optimizing your resuscitation team. With that, thank you very much.